Good evening, everyone. It's my pleasure to introduce Professor Basel El-Zorkany for the next talk. Professor Zorkany is a professor of rheumatology from Cairo University. He's a full member of ASAS. He is also a member of board of Egyptian Society for Back Pain and Secretary General of the Egyptian Society for Rheumatic Diseases. He had several key publications in international journals such as Annals of the Rheumatic Diseases. He had been invited as a speaker and or chairman in almost all major rheumatology events in Egypt and many other countries. His presentations are filmed and available on his website, with currently more than 600 rheumatologists subscribed to the website from several countries. Dr. Basel El-Zorkany is a friend to the Lebanese Society of Rheumatology. He will talk about updates in non-radiographic axial SPA. So, Dr. Zorkany, please, the floor is yours.
Thank you very much. I hope you can all hear me now. Do you hear me well, Nelly?
Yes, we can hear you.
Thank you very much. So I'm going to talk on non-radiographic axial spondyloarthritis about some current challenges and updates. And I would like to thank the Lebanese Society for Rheumatology for inviting me for this important event. I also enjoyed very much seeing Jonathan Kay in the last presentation. We had co-authored together. So that was very nice. Those are my disclosure and disclaimer. And I will try to cover 3 points quickly: the concept of axial spondyloarthritis, and what is the importance of early diagnosis, some highlights from the PREVENT study before I conclude. So to start with, I will cover the concept of axial spondyloarthritis to remind you that a group of interrelated disorders that share common clinical features, both musculoskeletal and extramusculoskeletal, commonly in the eye, in the skin, in the intestine. And when the manifestations are affecting mainly, predominantly the peripheral skeleton, we call them predominantly peripheral spondyloarthritis. When they tend to affect the spine, the pelvis, the sacroiliac joints, the root joints like the hips, we call them predominantly axial spondyloarthritis. My talk today will be on that part, only on predominantly axial SPA, and mainly I'll try to cover the non-radiographic axial spondyloarthritis. To clarify what are we talking about, I'm going to tell you about Mr. Tari. He had been my patient for many years, over 20 years. As you see his picture, well, he used to give me a visit every 6 months, and he is clearly having what we call radiographic axial spondyloarthritis. The old name, the most popular name, the famous name is ankylosing spondylitis. He has been stable on a biologic for many years, doing fine. But in a recent visit, he came saying, well, skip me this time, I'm okay, I'm coming for her, for my daughter, Malak. What about Malak? Malak is a university student, 21 years old, female. She had back pain for 5 months, especially the earliest minutes in the morning. Gave a history of right knee pain and swelling 1 year ago that lasted almost 1 week. An attack of unilateral eye inflammation, red eye 8 months ago. It shown photophobia, pain, excessive lacrimation, and it responded to local eye drops in about 2 weeks. So with the back pain for 5 months, it warrants to do an X-ray, and this was her X-ray. To me, well, the sacroiliac joint seems very nice, you can see them here. The margins are quite clear, distinct, no interruption, no blurring. Both non-radiographic axial spondyloarthritis and radiographic have similar clinical features and disease burden, because if we look for the clinical features, we find the same musculoskeletal and extramusculoskeletal patterns, no difference between them. If we bring patients with the same disease duration, and you will find that there is no significant differences as far as B27 positivity or family history or inflammatory back pain, the other features of the disease. And the only difference is that both patients can have the same disease activity, the same amount of pain, but it seems that the metrology is better, the measurements, the mobility is better in non-radiographic, and subsequently the function can be better. In a recent presentation, a plenary one by the large authority Desiree van der Heijden in the LSR 2019, she showed up that from 50 systematic literature research, there is similar disease characteristics, level of activity, quality of life, except that non-radiographic can have better spinal mobility and physical function. And that's why in the most recent physical meeting in the ASAS, we had a vote that as both non-radiographic and radiographic are parts of the same disease, the preferred term is axial SPA. That terms can be used interchangeably, that is to say, can be switchable, ankylosing spondylitis and radiographic axial SPA. And you can add non-radiographic to further describe some patient or some population for clinical studies. So in brief, to finish up this point, please stop discrimination in clinical practice based on imaging. Just use the term axial spondyloarthritis. Now I'm going to move to the challenges and the importance of early diagnosis. Let me tell you that to manage axial SPA in our region can be very challenging. We have a lot of things to consider in the management, but one of the most important things to me is the delay in the diagnosis. You know that the patient starts like this and progress over time. Many patients can become like that. We would like to diagnose them at that stage, not at the end stage as you see it on the right side of the screen. But we have troubles to do that. Our patients with low back pain visit orthopedic or neurosurgeons who had not very much aware of the axial SPA diseases, and also particularly the non-radiographic axial SPA. If they do an X-ray in the early stage, it can be normal. They can prescribe non-steroidal, and non-steroidal usually are very efficacious, and that's why they delay the diagnosis more and more. And sometimes, let me be honest with you, there could be some delayed referral due to fear of losing a patient, particularly in the private sector. And also the classic teaching tells them in the mind ankylosing spondylitis is a disease of young adult males with positive HLA-B27, which may not be the case all the time. If we look at that, we find that there is a gap of about 7 to 9 years between the symptoms and the diagnosis, and the gap is much more when the patients are B27 negative. And in our region, it seems that B27 is not very common like other areas of the world. General population may have a lower prevalence in the region between 0.3 to 6. While in the Europe and States, it's between 6 to 25%. And also several studies have shown that the prevalence between 40 to 50% in many areas of the region, from Egypt, from Morocco, from Lebanon. Some data on non-radiographic axial SPA from South Africa and the Moroccan region, also some data from the region giving us a prevalence of 38%. So it's not 90% as we see in the Caucasians outside. I had an analysis of 210 patients, and the mean delay of diagnosis was 8.25 years. And the usual journey is like that. A patient 40 years old, 9 years history of back pain, came to me in the last 2 years following with one same neurosurgeon with no improvement. He ordered new images and referred to me with these images after 9 years of low back pain. You can see that there are syndesmophytes, almost became bridging syndesmophytes in the lumbar region and also in the cervical region. Here you can see this. That was also very clear in the MRI, if you can just see it here. So those patients are the usual patient journey. And it's not only in our region. Data from United Kingdom shows that there is no improvement in the last 20 years with a delay between 8 to 10 years. The most important challenge in the Pan America, in the Latin America, is the late diagnosis. So it is a global issue everywhere. There is a delayed diagnosis. So how can we pick up the cases early? We need to look what we call for the gestalt of spondyloarthritis features. That is to say, the more signs and symptoms you see, the more likely the patient will have, after excluding mimicking disease, but only done by an expert, not just checking the list. Please do not use the classification criteria to make the diagnosis. This is an important point. And those are the SPA features that you can look for, starting from inflammatory back pain, which can be a good screening point, being very cheap, does not require investigation. Presence of arthritis, enthesitis, uveitis, dactylitis, the rest of the spondyloarthritis features, what we call the final shape or the gestalt of spondyloarthritis. I would like also to remind you and to tell you an important issue is that we had patients with back pain on sacroiliitis on MRI. After some time, some of those patients can develop radiographic sacroiliitis, and some others can also progress to have the final bamboo spine. But would all patients progress inevitably to ankylosing spondylitis? This is an important question, and really the answer is no. You can see that this arrow is not a continuous arrow, but it is interrupted here and there. And it's that only minority of patients for as long as 15 years had progressed. In one study that is a population-based, only 26% had progressed, despite that the numbers had been followed up for these years are somehow few. So please remember, it is not a pre-radiographic ankylosing, it is non-radiographic ankylosing. So some patients are going like that, some of them would progress, but some patients can remain as such non-radiographic, and please do not consider them as pre-radiographic ankylosing, but rather they are non-radiographic. It is one disease, but with a varying degree of structural damage. You can have patients with the MRI here that can progress to have some radiographic changes here, that can further progress to have this end-stage bamboo spine and bridging syndesmophyte. Why patients can go from this stage to this stage? It seems that the extent of inflammation and the interventions we do, it's minority, 25% to over 15 years. Some other figures are present also, but it seems that the presence of high CRP all the time, the presence of extensive MRI lesions are somehow prerequisite for this to happen. And if you look for the pathogenetic events that occurring, we see inflammation. After some times you have the damage, and this damage is repaired by the new bone formation. In the MRI, we describe this as acute lesions, what we call type A lesions, and this is as mature lesions or type B lesion. There is an interesting theory that if you treat the patient when they have these lesions with anti-inflammatory, you would probably not reach this stage, and then you would probably stop the disease. But this requires early diagnosis as a prerequisite for advances in disease modification, because this is what we call the acute lesions, and this is what we call the mature lesion. This MRI is from one of my patients. And if you treat the patients while in the acute, there could be no reparation process, a new bone formation. And in the mature lesion, unfortunately, there can be new bone formation. So if you start early, it could be much more advantageous. But this is a theory. Interestingly, this year in the EULAR, Xenophon Baraliakos have presented data to prove this. He had this background that we all know. We had osteitis that moves to fatty tissues and become a new bone formation. Now, the question or the research question, does the presence of active inflammation increase the risk of fat lesions? And if early resolution of active inflammation will dilute, mitigate the development of fat lesions? The conclusion was very interesting, because this is a placebo-controlled study for 4 years. Reduction of inflammation by week 12 mitigated or diluted or lessened the fat lesion risk on the long term, indicating the importance of early, effective, and long-term treatment targeting inflammation. Unfortunately, those patients seems to be less treated. If you look for the data came from the last ACR 2019, despite that the patients are having the same disease spectrum, patients with non-radiographic axial SPA are treated less with biologic. Data from the Spanish registry, it shows the same thing. Patients with non-radiographic axial SPA had lower use of biologic therapy compared to axial SPA, despite that the overall socio-demographic characteristics, patient-reported outcome, employment states, everything, both groups reported similar trends. But non-radiographic are less treated with a biologic. And this is very interesting manuscript this year. The results confirmed the concept of axial spine disease, which implies that both should be treated with equal priority. Don't distinct between them. The distinction between radiographic and non-radiographic should only have implications for clinical research, not for clinical practice. I'm going to now move to the final point, which is some highlights from the PREVENT study. The PREVENT study is one of the largest study. In fact, it is the largest one for a biologic DMARD in non-radiographic axial SPA done on 24 countries, 555 randomized patients. Patients were included depending on the fulfillment, the ASAS classification criteria, but excluded if they have the modified New York criteria, because they have excluded if they have radiographic evidence. We need them non-radiographic, with a B27, with CRP high, with MRI findings, etc. What happens here? The early results presented last year in the ACR, the first 16 weeks results were available, and simply all the primary and secondary endpoints were met with the same, what we know about the safety. The safety was doing fine for this group in the first 16 weeks. The primary endpoint was the SS40, which is highly significantly different than the placebo group, and also all the secondary endpoints, but I'm very much, well, the SS40, the total BASDI, the BASDI 50, the BAS-5, the SS partial remission, everything was going well and highly significantly different from placebo. The most important thing to me is the objective signs of inflammation, that at 16 weeks, there is a reduction in the bone marrow edema of the sacroiliac joints in the group, this dark blue, who had received the classic way to give the treatment with loading and every 4 weeks, 150 milligram. And also CRP had been, high sensitive CRP had been decreased markedly over these 16 weeks. Now this year, the data for 1 year has been available. The benefits we gain at week 16 has been maintained to week 52, much more higher. And SS40 has been significantly different than placebo as well. And also all secondary endpoints, the BASDI, the BASDI 50, the decrease, the BAS-5, the functional index, the physical function, the quality of life, the everything. But also, again, what I care about CRP as well, the MRI, because the achievements obtained at week 16 had been exponentiated to be highly significantly different at week 52 for decreasing the bone marrow edema, that is to say the inflammation, the osteitis of the sacroiliac joint, and this is an important thing. And this can be very important, especially when coined that the safety were okay. There is no significant differences in any safety measures. If you look for serious adverse event, if you look for death, zero at all the things. If you look, for example, the common thing we see is nasopharyngitis. It occurred in 25%, but 32% in the placebo. So there is no significant difference between both groups. So now I hope it was not too long, and I apologize for the technical issues, but now it's time to conclude. My conclusions, as usual, are brief. I would like to tell you that axial SPA should be viewed as one disease and should be diagnosed by the presence of gestalt of spondyloarthritis features, the full picture, not by classification criteria, please. Several challenges affect management of axial SPA. Awareness and referral are related much to the delay of diagnosis. Not all cases of non-radiographic axial SPA progress inevitably to ankylosing. It is not the usual continuum of ankylosing. No. Non-radiographic axial SPA can have better prognosis if treated early, yet it seems, unfortunately, that they are less treated with biologics. Biologic DMARDs should be prescribed with equal priority to radiographic and non-radiographic and should depend on objective signs of disease activity, of inflammation in the CRP, in the MRI, not directly on the imaging. If you see damage, then you prescribe biologics. If you don't see the damage, you don't prescribe, because the patients have the same amount of pain and disease activity. And finally, secukinumab, largest study on non-radiographic axial SPA, showed promising results and imaging, clinical and imaging results, as all primary and secondary endpoints are met. Mr. Chairman, Dr. Nelly, thank you for inviting me. I think we still see patients like this we hope that we will be able to prevent this from happening with the early diagnosis and prompt management. And thank you very much.
Thank you, Dr. Zorkany, for the excellent talk, as usual. We have some questions. Some of them you already answered, so I will try to combine the non-answered one. The first one is, can we still label someone as non-radiographic axial SPA if the patient meets clinical criteria, clinical symptoms and signs, but negative MRI and negative HLA-B27? So this is the issue of classification versus diagnosis.
Yes, exactly. The issue is that the diagnosis should be done by the rheumatologist. It is a rheumatologist diagnosis. Yes, you think from the features you see in this patient that he will fit the axial SPA. Being non-radiographic or radiographic is another issue, and it should be left to research purposes, not to clinical management.
Okay, I agree. Thank you. The second question is, somebody is asking about the extra-articular manifestation. Is the prevalence the same in radiographic and non-radiographic axial SPA?
Yes, from the data presented by Uta Kiltz and the data of Martin Rood-Wallet, it seems that the prevalence of both is nearly the same. No significant differences.
Okay, and the last question, since MRI is an important prognostic factor, do you personally think that we should follow the patients by MRI before taking any decision, for example, before tapering down the treatment?
No, I do MRI only when the results of the MRI is likely to change my management. If there is no need, I don't do MRI as a routine procedure.
Okay, Professor Zorkany, it was a pleasure having you at LSR. We thank you for your valuable contribution.
Thank you very much. I hope you are a very successful and fruitful meeting for the rest of today and tomorrow. I enjoyed that very much. Thank you very much.
Thank you.